person poses a significant threat to the public, they have to be let out. So forced risk assessment. And in Canada, that's when a lot of the research and development of risk assessment instruments took off. And I think that a lot of countries have been kind of faced with that over the last 20 years, that kind of situation. We published version 3 of the HCR-20 a few years ago now, 2013. About half of the research on the HCR-20 is in forensic psychiatric settings. But as you can see, there's also a lot of research in prison settings, mixed settings, so that's, say, general psychiatry and forensic patients, civil psychiatric settings, and there's even been some research with kids, with juveniles. Over 300 studies based on, I estimate, about 175 data sets, and probably somewhere between 30 and 40,000 patients and offenders and research participants. In more than 40 countries now, there's been research and use. There's more than 20 translations of the HCR-20. I'm really happy to see the Arabic one coming along so nicely. There was a survey by Jay Singh, published in 2014, of 42 countries and about 2,400 clinicians. And the HCR-20 was the most commonly used risk assessment instrument across those 42 countries. So some basic research questions. Is there predictive validity of the risk factors? So we have those 20 risk factors. Are they actually related to violence? So basically what we do here in research studies is you rate the risk factors and then follow the patients up and look at who is violent, who is not violent, and see if there's some kind of connection between the risk factors and who is violent. There's probably now 8 or 10 meta-analyses, so this is quantitative summaries of research on risk assessment, including the HCR-20. So I'll tell you just about one of those by Yang and colleagues. Looked at 9 different instruments, including the psychopathy checklist, which is a measure of the personality disorder of psychopathy. This was 28 studies that used more than one measure, and they compared whether any of these risk assessment measures improve upon the predictive validity of the psychopathy checklist. Do they do better than if you just know that somebody is a psychopath? Okay? So what I'm going to do now is I'm going to show you something that violates all the rules against good presentation skills, because I'm going to do that. Okay? But I'm just going to guide your attention. I'll guide your attention. So these are all a bunch of different risk assessment instruments. These are correlations. So if you know about correlations, you know that they go from -1 to +1, and +1 is perfect. 0 is no correlation. So 0.37 for the HCR-20, and it's close to a couple of other measures, but then they all fall off after that. AUC values, for those of you who know, we don't have to get into detail. Those would be low from a surgical or medical diagnostic standard, but they're, in our field, reasonable. Only 2 measures added incremental predictive validity to the psychopathy checklist. So one of them was the HCR-20. That is, its strength of association with violence was stronger than the psychopathy checklist. The other was something called the Offender Group Reconviction Scale, but that's only based on 2 studies used in British corrections. Okay, Interrater reliability. Can people agree? So if I fill it out and you fill it out, do we get similar answers? We did a study on version 3, based on 35 Swedish forensic patients. 3 raters went and interviewed each patient, reviewed their files and so forth, independently completed the HCR-20. So, more numbers for you. These are also a type of correlation, inter-class correlation. It's Interrater reliability. ICC-1 is the reliability of 1 rater. ICC-2 is the reliability of averaged raters, the 3 averaged raters. So this is the different scales. That's for institutional violence. That's for community violence. Again, institutional and community. Final risk judgment of low, moderate, high risk. The bottom line is that Interrater reliability was good. ICC-2s, all above 0.8, and many in the 0.9 ranges. Reliability of 1 is perfect. and you pretty much never see that. Predictive and incremental validity of summary risk rating. So when you use the HCR-20, you're encouraged to come to a judgment of whether the person is low, moderate, or high risk. That can inform discharge decisions or the amount of management that a person receives. It's important to know whether those judgments, which are not based on formulas or numeric cut points, they're your professional judgments, if those are predictive of subsequent violence. Again, another study with version 3 of the HCR-20. This is in 106 civil psychiatric patients and offenders. There's plenty of studies in the forensic realm on this topic as well. File plus interview, it was a prospective study. We followed people up 5 times after discharge. So we interviewed them and did a file review while they're in the jail or in the hospital, and then we met with them 4 to 6 weeks later, and then 4 to 6 weeks later after that, 4 to 6 weeks later after that. And it's hard to find these people in the community often. I live in Vancouver. It's about the size of 1/10 of Cairo, right? So it's a big city for Canada, about 2 million people. People who leave psychiatric hospitals and jails don't often necessarily want to come back for a research interview. So we have to go find them. So my PhD students were wandering around the streets of Vancouver at night, going into bars, trying to find their research participants. One of my PhD students actually interrupted a drug deal. So one of our research participants was buying drugs. And my student Adam went up to him and said, "Hey, is this a good time for your research follow-up?" And the guy's like, "Hey, just wait a second." So he waited patiently, and then the guy came over and they did the follow-up. I don't force my students to walk around through the back alleys of Vancouver interrupting drug deals, but some of them actually kind of like doing that. So we did a 4 to 6 week follow-up and a 6 to 8 month follow-up, looking at these judgments of low, moderate, and high risk. So again, for those of you who do like correlations and AUC values, those are good, healthy correlations and AUC values for the combined sample, for the psychiatric sample, and for the offender sample. For those of you who might want to look at a graph instead, this is the percentage of violence as a function of whether the person was determined to be low, moderate, or high risk. So a judgment of low, moderate, or high risk was made by our research team, and then 4 to 6 weeks later, in the low risk group, there was 1 person was violent, so that's about 2%. In the moderate risk group, it was about 15%. In the high risk group, it was 45%. That's in a month to 6 weeks after discharge. 6 to 8 months later, low risk group, about 15% had been violent. In the high risk group, about 65% had been violent. All this is showing you is that if you use this method and you use your judgment, it's a meaningful judgment. It means that if you say high risk, there indeed is a much greater chance that that person will go on to be violent than if you say low risk or moderate risk. A lot of numbers here. The general take home from this, for those of you who are research friendly, you can just read it and you'll understand it. The basic message here is that those summary risk ratings of low, moderate, and high risk do a better job at predicting future violence than if you were to just add up the risk factors. Okay? There's something about the clinician bringing their experience and expertise to bear upon a case where you can make better sense of a case through the integration of information than if we just simply added up how many risk factors a person has. I said that the HCR-20 is used to monitor change. So what that means is if you're seeing somebody develop more risk factors, you should get more worried that violence is about to happen. If they're getting better, then violence will be less likely to happen. So we looked at that in some research in Sweden, in a forensic hospital, measuring the current functioning, the C scale, the clinical factors like insight problems, violent ideation, and so forth, every 6 months for 2 years. So this is a drop over 2 years. It's not a huge drop. It actually only goes down about half a risk factor. If you were to add up the risk factors for research, this scale can go from 0 to 10. But that change predicted violence. So for those who improved, there was less violence in the next 6 months. For those who got worse, there was more violence. But we thought we might have obscured some change. So we did a procedure called cluster analysis, which is finding groups of people who are similar to each other but different than other groups. And we found 5 groups of people who showed different types of change in risk factors. So you have this group who dropped actually quite a bit on their risk factors over time. This group dropped, but they started out higher. This group actually got worse. So they got worse for a year and a half, and then they kind of leveled off. This group started at very high risk, and then got better. Okay? So again, just evidence of the basic assumption of this model that it's good for monitoring change. That if there's change, you'd likely be able to pick it up. This change was also associated with violence. So the blue bar is the HCR-20 clinical scale score over time, the blue line, and the green bar is the percentage of violence in the next 6 months. So you can see, in general, as the risk factors go down or get better, violence goes down. As the risk factors get worse and then level off, violence gets worse and then levels off. Similar study by Steph Petty that's in a forensic setting. So what I want to do as I kind of come to a close is just tell you a little bit about how we developed and validated the version 3 of the HCR-20.